So the drugs I selected this morning, I selected on purpose because they're drugs that could potentially have an important role in primary care practice itself. That is, drugs that I think that primary care internists can become competent and comfortable prescribing. There are certain drugs which would really never be in our sphere, such as most of the biologicals, for example, which are almost all specialty medicines. The ones that we talked about this morning are all drugs that can be safely used in primary care practice after internists learn about the types of things we discussed this morning. Safety, contraindications, efficacy, and then how to actually prescribe the medicine. So my goal for the talk was to help primary care internists feel comfortable actually prescribing these drugs themselves and not deferring to a specialist. For me, the decision about which drugs to select was somewhat subjective, and someone else might look at the same list and come up with a different group to present to the attendees. However, the ones that we talked about this morning are ones that can have potentially an important role in addition to existing therapy and can be safely used by primary care doctors. I would say that with only one or two exceptions, the biologicals will almost always be specialty medicines. There are certain medicines where the harm is sufficiently great that patient selection is important. So in order to accept that degree of harm or risk, there would have to be a clear benefit to a subset of patients. And those are medicines where we might ask the specialist to help with as well, for example. The ones we talked about this morning are ones that I feel that primary care doctors can use. Not that all four of them should be used, but they could be used, and that was the reason for discussing them this morning. Well, I didn't focus as much today on therapeutic lifestyle change in the discussion of my drugs because the focus of my talk was on new drugs for primary care. But for each of the drugs, we did talk about the importance of, when it is relevant, which it often is, therapeutic lifestyle change in many cases first or in addition to medication. And I didn't mean from my discussion to imply that medicines would always be the first or only treatment, that in many cases, particularly, for example, diabetes, as we talked about today, lifestyle changes as are more important than the initial therapy. And in terms of referring to subspecialists for more of a cognitive opinion, I think that would be more of an issue when the diagnosis is in doubt or if they required specialized testing that goes beyond what we could do. So, for example, coronary angiography that we'd require our specialty colleagues to help with.